Welcome to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Continue your learning after the show at www.drjournalclub.com.
Please bear in mind that this is for educational and entertainment purposes only. Talk to your doctor before making any medical decisions, changes, etc. Everything we're talking about, that's to teach you guys stuff and have fun. We are not your doctors. Also, we would love to answer your specific questions. On drjournalclub.com, you can post questions and comments for specific videos, but go ahead and email us directly at josh@drjournalclub.com. That's josh@drjournalclub.com. Send us your listener questions and we will discuss it on our pod. Hello and welcome to another Dr. Journal Club podcast with Josh and Adam. We are in rare form today, ladies and gentlemen. I am running around like a chicken without a head, trying to catch up after being gone for a couple weeks. Adam is leaving us tomorrow.
Deuces.
He's moving to Vermont after all this time. He's still going to be on the podcast. He's still going to be around. He's just going to be in a new locale, but he's like moving. His house is in disarray. He's been up all night packing.
Whoa. Not in disarray.
It's very clean because there's nothing in it. All right, to clarify, apparently he's a minimalist, and he spent all last night taking down IKEA furniture. So, as one does. I feel like you could just sledgehammer. If you're going to take it apart just to go to the dump, just sledgehammer that stuff. Be way more. I guess you can't do that in the middle of the night. Your neighbors will hate you.
I could do that. It's just, I don't think people would appreciate it.
No, and the HOA would not be pleased. We were just chatting about...
Are they ever?
I don't think so. I mean, I've never had to interact with them. I've only heard nightmares. Is it as bad as they say? Is it just people like that don't have anything else to do and just...
Yo, shout out to all the HOA managers out there listening to the podcast.
If they're still listening after my uninvited commentary. All right, so Adam is running on 1 hour of sleep, 2 hours of sleep?
3.
3 hours of sleep, which apparently means you're drunk. Is that what you were saying?
Actually, it might be less than 3. Well, it's 3 hours of sleep, but I was up for 23 hours.
I'm pretty sure you're drunk. So there's that. And because, ladies and gentlemen, we're so on top of our game, we've prepared the wrong paper for today. So our dear colleague, Dr. Bill Walter, requested that we do a paper, and I don't know what I did. I said I'm going to claim that it was because of the craziness after travel, but I think I pulled the wrong paper and prepared the wrong paper. So today...
Well, hold on. You're talking about craziness of travel. Give us an update on some life stuff. You had some pretty big things happen. I think people should, know about our life. This is a family here.
This is a family. What are we talking about here, Adam? I mean, there's a lot we could share. What in particular are you referring to?
Well, you had your triathlon.
Oh, the triathlon. Yes. So, I had my first triathlon. Adam and I have been training and did my first one. I nearly died multiple times, like literally nearly died multiple times. It was like, I finished. So like the take home is I finished, right? Okay. Can I just tell you briefly how crazy this was? So I live in Colorado. We don't have open water. The race was in San Diego in the ocean. And so I had been in my wetsuit twice and not in the ocean. And anyway, long story short, I've been training in a pool. So, you do a few strokes, and then you like catch your breath on the edge and swim back, right? And so like I'm kind of used to doing kilometer and a half, 2 kilometers, but like with these little breaks. And I don't think I realized what kind of impact that would have with just continuous swimming. So pretty much I'm like out there feeling amazing, get to the first buoy and I'm rocking it. And then I just start like dying. I'm just like like out of breath every 10 like strokes or whatever. I'm just like having to take a break. I'm not making any forward progress. One by one, all the waves after me start passing me. And when like the grandpa wave starts passing me, I'm beginning to get a little freaked out. And I start looking behind me, and there's like nobody left. I'm like the last person in the water. I'm not making this up. The lifeguards and the quote unquote swim buddies are like gathering around me. They're like, man, this guy is in trouble. Like, we gotta be at the ready. And they're like, doing their business and be like, hey man, you okay? I'm like, I think so. Anyway, so I finally make it out of the water, and I had like lost so much time, and I'm like surprised I'm alive, because like 5 times in there I was like, not quite a panic attack, but like those panic moments when you're like, wait a second, I am so far out, like I don't know about this.
I'm going to die.
Anyway, so that was horrific. I get out, which is like a small miracle. I'm still alive. My sister later tells me that there's like stingrays in there, and they regularly, ray people. And I'm like, oh great, that's cool. Anyway, so I'm out, right? But I'm so freaking late. And so I get on my bike and I start pedaling, and you do these loops, but it's a busy San Diego section, and they had to close the bridge at a certain point. And on my second loop, I freaking miss the deadline for the turnoff by like 3 minutes. But the guy took pity on me. He's like, oh man, you're so close. Like, just go, right? And I'm like, oh, awesome, right? I'm still going to finish. So I go. But he didn't realize this, but the other guys have already removed all the cones and the signage and the guardians from the traffic. So now I'm like basically on-ramping onto a massive highway with no signage. I'm like, it's like so bad. Anyway, long story short, I like get lost. I lose my way. I'm like trying to find my way back to the course, and this is just so bad. And then I'm 3 miles out. Like I finally figured out where I am. I'm 3 miles out, and my freaking bike breaks. Like the pedal, like I'm not making this up, literally cracks off. Like it like literally cracks off. And I'm like out there, I had my kit with me, and I'm like, okay, like maybe I can fix this. Like, but no, the threads are fully destroyed, like cannot fix. I'm sitting there with like a wrench for a good amount of time. Nothing is working. Like, I cannot salvage this. I tried to ride it with one pedal. That doesn't work, just in case you were curious. And I'm like, oh, by the way, I'm in like a heroin den. So I'm like on the side of the highway trying to make my way back to the course. And I'm like surrounded by the sketchiest people on the side of between a skate park and a highway off ramp. And I'm on this, like, I look like an idiot because I'm like geared up for triathlon, and my freaking pedal. Anyway, so now I'm walking the bike the last 3 miles back to the transition zone. And I'm just like, this is just absurd. They're going to close me out for time, right? And but I'm like, I'm going to finish. And I finally get in, and I'm like, is it too late? Like, my bike freaking broke on me. Can I still run? And they're like, I guess. And so I run, I transition, I run, and I make the first round, and I've got one more loop, and I'm like coming up, and you think you're doing okay, and then you realize that everyone that you were passing and you were feeling good about yourself were actually on their second leg, and you're still on your first. Anyway, so I finally make it. I'm on my last leg. Like, the guy who's doing running cleanup is like, oh, I thought you were ahead of us. I'm like, no, I had another loop to do. Anyway, so I crossed. I must have been the last person or one of the last people across the finish line. But I don't know, man. I finished. I'm proud of myself for finishing. And it was just like so many lessons learned about swim training, about proper gear, about knowing the route. Like, I'm used to races that are like, running races that are so well delineated. I was like, I'm not gonna get lost. Like, that's not a thing. Yeah.
And you did it all without music or podcast because you couldn't wear.
Oh yeah. And then right before, they're like, oh yeah, just so you know, because I know nothing about triathlons, just so you know, you can't listen. You're not allowed to wear headphones. It's a full disqualification, and there's like penalty boxes and like all this crazy stuff, and there's like uniformed whatever, and I was like, I've trained with podcasts and music, like I've just not. Anyway, so instead, what was going through my head the whole time in the swim was, I'm gonna die, I'm gonna die, I'm gonna die, I'm gonna die. They're passing me, they're passing me, they're passing me. And then on the bike was like, oh, when I was in the heroin den, it was like, I'm gonna die, I'm gonna die. And then on the run, it was just like, I gotta freaking finish this thing.
You know what that sounds like? Sounds like med school or a
Really? I mean, I bet that. Tell me more. I kind of like that analogy.
I mean, the entire time, instead of saying I'm gonna die, you just think, what the F, what the F, what the F, what the F.
Yeah. And then there's like some random thing that you get through, like you get through finals, and then you're like,
And then you go into residency.
oh wait, it's just a whole nother.
That's your bike pedal breaking right there.
Yeah, that's like,
And then you just finish.
yeah. And then you just finish, and at the end you're just like, I mean, I guess I'm proud of myself, but mostly I just like,
I'm just happy I lived.
and then so like I mean it's good. I mean, there's lessons to learn on all this, but at like most of the only reason I think I got out of the water was like the whole time I was thinking about Theo, and I'm like, I want to be able to tell him that I finished, right?
No, but think about it. I think that's super cool. You're a physician, a PhD candidate, and a triathlon finisher.
Yeah, well, I didn't know it was a finisher until the end, and then like I get across the finish line. Theo's there. The first thing he says is, Abba, what place did you get? First place? Second place? What place? And I was like, finisher place. Yeah. So anyway, but I'm still hooked, man. I mean, I'll tell you what, though, I am not doing a half Ironman next. Like I had no business being in that race. Like it is a miracle I got through it. It was international, which is essentially Olympic.
What was the distance on that one?
Kilometer swim, 50K bike, and then a 10K run. And yeah, so it's like essentially Olympic. I don't know why they have different ones. I think the Olympic is 1.5K swim, but like you double that for half Ironman. I need to prove to myself that I can actually complete a race without, with like normal conditions. And so I'm going to do another triathlon Olympic before half
in less simulated conditions.
But we'll talk about training. Yeah. Later. Anyway, so lots of stuff. And then you're moving, which is a huge deal. At some point, we should talk about integrative medicine and research. But then we did the wrong paper. Did we already talk about that? We picked the wrong paper to prepare?
Mm-hmm.
You didn't even read the paper. Yeah, we're doing great, guys.
Well, you read the wrong paper. I didn't read the paper. So we're doing this live.
So there's some options. We could just cut this whole thing and like take pity on our listeners. The other is we could do like just a live, like straight up no prep review of the paper we were supposed to read, because the paper that I read is actually pretty much garbage. Like I was like very, very unimpressed, and I was like, what is Bill thinking? But actually he wasn't thinking that. He picked a different paper. So what's that?
Knowing Bill, he wouldn't do that.
No, he wouldn't do that. But apparently knowing Josh, like, can't even like track down the right paper here.
So yeah, let's do this. Let's do this live.
Yeah.
Let's show the people how easy it actually can be to break down a research article when you've been up for 23 hours and then sleeping for 3, and then you're coming back from dying from a triathlon, and then resuming life.
I hope this wasn't a tough one.
Yeah, let's show the people, and also shout out to our listeners. We had a lot of communication from the community this week.
Okay, let's show the people.
Yeah. Keep requesting them, by the way. It's awesome. It's really encouraging to hear you guys say that people are listening to this show. Shout out to Dr. Jen Ryan, everyone else who's listening.
Yeah, we can't fall behind. We've got a bunch of papers people have requested, and topics. Dr. Garovich, who else reached out? Dr. Kane reached out again.
Everyone who's listening, just sending papers and whatnot. So Thanks, guys. Thanks for the support. We really appreciate it. I find it motivating when you guys send us stuff. It makes me feel like it's not just us two actually talking to
Randomly
each
across
other.
the void. Yeah, no, I agree. It's awesome. It's kind of nice to have a glut of stuff. So I've got a hard stop in 36 minutes. So what I'm going to suggest is
Shoot.
we probably jump in as much as we can. We probably do half of it now, and then we can finish up next week. But let's just see what we got. So, okay, we're looking at it front and live, people. So here's the paper. And we'll send a link we'll include a link, of course. It's in JAMA Psychiatry, effect of pain reprocessing therapy versus placebo and usual care for patients with chronic back pain. Randomized controlled trial. So we've got a randomized controlled trial, patients chronic back pain, and they're going to use pain reprocessing therapy, which is news to me, versus placebo and usual care. So let's start with that. Are you familiar with this intervention at all?
I'm assuming it's some sort of form of like pain education. That's going to be my guess. Is kind of talking about pain. There's when it comes to pain management, we're kind of trying to move away from chronic opioid use. And really trying to transition people to safer options or not starting them in general. And then especially for individuals with chronic pain, it's a very complex type of pathophysiology there where there is a lot of mental component, and it's not, don't get that confused with pain is in your head. That is not what we're saying at all. However, there is a very strong psychological component to it. And if you think about like phantom pain, right? People who may have had a limb amputated for whatever reason may have pain in what used to be that part of the body. However, it's not there. So it's like, how can you feel pain for something that's not there? And if you were to run a diagnostic imaging on people, especially with low back pain, it's kind of why we're trying to not do so much imaging on people with low back pain is, if you want to find something, just order an MRI and you'll probably find something, but doesn't necessarily mean it's actually explaining the pain. And so you can have pain without trauma and trauma without pain.
I like that.
And so one of the interventions that, when it comes to pain is actually just pain education. And there's a whole field dedicated to that. So that's what I'm thinking it is. But, like I usually do, if you're pressed on time, just skip the entire introduction and go all the way to the end. And the last sentence or two is what's going to explain it. And that's what we see here. And they say very directly, in this study, we conducted the first test of PRT, which is that pain reprocessing therapy, in a randomized clinical trial with 1-year follow-up comparing pain reprocessing therapy with open label placebo in usual care conditions. So that's interesting. Methodologically, Josh, what's open label placebo?
So you're giving somebody like a placebo or some form of sham, but you're telling them it's a placebo, which is like amazing. And actually, there's been some research out of Harvard with the Capshuck lab suggesting that like even if you tell people that something is a placebo, like it still works, which is kind of crazy. So that's what I'm envisioning they mean by open label placebo there, and then usual care is straightforward, pretty usual care. This is good. I really like that you're going to be able to see how we read papers like without prep. So I would agree that last sentence in the introduction is going to just summarize things really quickly for readers. So if you have an article, read the title, go to that last sentence for sure. The other thing I'd always do is I eyeball the authors. I didn't recognize any of the researchers here. And then you always want to check their affiliations. It looks like the author affiliations are listed at the end of this article. So I'm just going to scroll down real quick, just like the order that I would kind of take a peek at things and see. Let's look at conflict of interest. And so research affiliation. So what I'm looking for here is just to make sure everyone's academic. It's okay if they're not, but I just want to know if anyone like works for maybe a company that sells this product or sells courses about this product. So there's the Institute of Cognitive Science, University of Colorado. So that sounds academic. Pain Psychology Center. Yeah, so we would probably Google some of these to see, are these places that exclusively do this? Is this a patentable process or approach? And let's see, conflicts of interest, see if they disclose them themselves. NIH funding, that's good. Here we go. Personal fees from United Health Group Incorporated, Pain Reprocessing Therapy Center, and Mental Health Partners of Boulder County outside the submitted work. So I guess one question would be, so this Pain Psychology Center or this Pain Reprocessing Therapy Center, so clearly there would be potentially some conflicts there. Just to bear in mind, doesn't mean we can't trust the stuff, just kind of understanding. Book royalties from Unlearn Your Pain, which may be related to this approach. So it sounds like people have intellectual, potentially financial conflicts here, and understandable if people are sort of passionate about a particular approach. So we'll bear that in mind. And anything else we should look at before jumping in from your perspective?
No, looking at the methods, it looks like they're going to kind of break down some more stuff that we'll get into.
Okay, cool. So, so that's good. Then the last thing I'd look at on that first page, then, besides eyeballing affiliations and funding, is to see if there's a trial registration. This one does have one, which is excellent, and it's sort of clickable. So they have a clinicaltrials.gov identifier, so you can open that. That is a good sign. Ideally, it's done a priori before the results, and it hasn't been changed. But that's one way you can check their work. So that's something that I spend more time. We'd open that up and compare. But at the very least, the fact that it's there is a good sign. And then, good. All right, so let's jump in. So actually, I just want to say, how would we look at the introduction? So the first paragraph is usually about the condition. So this is like, blah, 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 chronic pain's a problem. So that's kind of like a no-duh thing. There are some options, but they're not great. And then they start talking about setting us up for understanding the intervention. They talk about interoception, different ways of addressing pain, some of the stuff that you've been talking about. So that kind of sets us up for the intervention. And here we go. We developed pain reprocessing therapy based on this understanding. Okay, so it sounds like they developed this. Okay, so now like my initial red flags, again, so red flags has a negative connotation, but it's just sort of things that alert me to pay closer attention, are now like flashing. We developed pain reprocessing therapy based on this understanding. So they invented this technique. Okay, so now they're clearly conflicted. Again, doesn't mean it's bad, doesn't mean we can't trust it, but we need to bear this in mind. To understand primary chronic pain, leading psychological interventions, blah, blah, blah. PRT, so that's pain reprocessing therapy, emphasizes that the brain actively constructs primary chronic pain in the absence of tissue damage, and that reappraising the causes and threat of value of pain can reduce or eliminate. So that's exactly what you said. So they developed this. That's the framework, and this is the first study of it. And it's impressive that they did a randomized trial with 1-year follow-up, and they had open label placebo. Okay, I am now ready. Hold on. Yeah. Mm-hmm.
And before you get into that,
Okay, talk to me.
they even use some more objective data too, and they yeah. So basically, what they said was that they further kind of further sort of like looked at what they were doing using fMRI, so functional MRI, with both spontaneously occurring and evoked back pain. So basically, back pain sort of happening organically, and then also back pain that's somehow that they induced it, whether they kicked them in the back and then asked them to talk about their pain, or if they were just kind of in a naturally occurring acute pain flare.
That's fascinating. This is so cool.
So then they'll have like a correlation between, okay, how is our therapy, working for your pain,
mm-hmm.
while we're looking at functional MRI in the setting of actual pain.
Oh, this is so neat, and with open label placebos and with unblinded interventions, because how could you blind something like this? Having some form of objective measures is really important. So this is great. So far, I'm like, wow, here are some clinicians who invented this thing to help people, and they maybe made a center or whatever it sounds like, but they're not. That's not enough. Now we're going to study it rigorously, and we're going to do it with fMRI. So I'm like super impressed at this point. Okay, so that's so cool. And so let's jump into the methods. First sentence. Oh, this makes me so happy. The trial was pre-registered on clinicaltrials.gov. So they did do it a priori, which means that basically they said, this is the stuff we're going to care about before we see the results. So this is really important. I was talking about this. We were talking about this last time, which is like, okay, let's say you have a conflict, right? Like funding, industry, pharma, whatever. What do you do to minimize the potential risk of bias? And one of the things I think that's most important is having reasonable pre-registered a priori protocols, because then it's like you can't wiggle out of that later. Mm-hmm.
Or
Yeah.
Or you just don't say anything.
Or you just don't say, or you just ignore it and pretend like nobody notices. Yeah.
Yeah. That's my preferred method.
That's your preferred method. Okay.
Yeah.
So this is so far so good. So I'm like really excited about this. This reminds me of years ago, I was at a Cochrane conference, and there was a presenter, and the guy had invented some form of like acupressure bead or something, and he was up there talking about his randomized controlled trials and his Cochrane review of those randomized controlled trials. And he had gotten like some criticism, like, well, all these, you invented this, all the studies were done by you, and you did the meta-analysis. And he's like, please do it as well. We are desperate for other people to do the randomized trials. We are desperate for other people to do the systematic reviews. It's just that no one's doing them, and we think this can help people, and so we're doing them. And I just love that. And I was like, yeah, that's great. Like, you just got to make it happen. Look, the thing is, we don't do this for money. This is pro bono, and quite honestly, the mothership kind of ekes it out every month or so, right? So we do this because we care about this. We think it's important. We think that integrating evidence-based medicine and integrative medicine is essential, and there just aren't other resources out there. The moment we find something that does it better, we'll probably drop it. We're busy folks. But right now, this is what's out there. Unfortunately, that's it. And so we're going to keep on fighting that good fight. And if you believe in that, if you believe in intellectual honesty in the profession and integrative medicine and being an integrative provider and bringing that into the integrative space, please help us. And you can help us by becoming a member on Dr. Journal Club. If you're in need of continuing education credits, take our NANCIAC approved courses. We have ethics courses, pharmacy courses, general courses. Interact with us on social media, listen to the podcast, rate our podcast, tell your friends. These are all ways that you can sort of help support the cause. Okay, cool. So they registered it, 1 year follow-up also. So really nice long follow-up. They have the fMRI data. Good. Let's see, what else? Participants were 21 to 70 years old with back pain for at least half of the days in the last 6 months. So that sounds like definitions of chronic back pain. 1 week average pain, 4 to 10.
Meaning a pain intensity score of 4 out of 10, where 10 is the highest amount of back pain.
So it's not minimal back pain, right? If you're averaging 4 to 10.
It's like that chronic nagging back pain that a lot of patients will come in for.
Yes, exactly. So very clinically relevant. 4 of 10 or greater. Okay, yeah. So you have to get at least 4 or above. So basically, this isn't the mild thing. Recruited out of Boulder, which is nearby. Primary chronic back pain, blah, 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 blah. Okay, they talk about power analysis, which I think is almost always boring.
It's boring, but it's important. So basically, how many people do they need to recruit into the study in order, in this case, to get a medium effect size on the pain intensity?
Oh, look at that. Yeah. Nice. Okay, so this is this is a great paper. So nice job, Bill. So and nice job, authors. So they're powering it to see a medium effect size. So like that would be an effect size that like actually matters to patients. So they're not overpowering it where they can see some minuscule difference. So that's very cool. I like that. They passed a IRB, Institutional Review Board for Ethics. They followed consort flow guidelines for randomized controlled trials. This is all excellent. So far, so good.
And then they were randomized to the treatment group, placebo, or usual care.
So it's 3 arms. So they either got this intervention, a placebo, or usual care. Okay, interesting. Okay, so there's 3 arms. And they were balanced on age, sex, baseline pain, and opioid use. That makes sense. Those are all important covariates or drivers of pain response. Primary endpoint was 1 month after the baseline fMRI, and then they did online follow-up assessments 1, 2, 3, 6, and 12 months later. So far, I love all of this. I'm just like, acutely aware that they have strong conflicts, and so you're looking for a strong design to overcome that. And so far, I am seeing a strong design.
It's kind of like it's almost too good to be true right now. So where is the aha?
Yeah. Well, we don't know what the results are. Maybe they didn't work. I don't know. Let's see. Okay. So interventions. So
So basically, just talk about like
Okay.
PRT, what it is. Uh,
So tell us a little bit about when you're eyeballing that. What is your take home?
Basically, it's like cognitive behavioral therapy for pain.
Okay, so that's our 30-second assessment. Okay, they would probably disagree, but
Well, but here's the thing: like as a clinician reading this, I'm not trained in this type of therapy, so I would have to place a referral anyway.
oh, that's fair.
So, and that's something that we have to kind of take into consideration, right? Say these results were
That's true.
amazing,
Good point.
and yes, I have patients who fit this, like everything would be great, but where am I going to send them to?
Right.
Because I don't have the training for this. Do I have the time for this? In a given appointment.
That's right.
And then, if I send them to, let's say, a counselor or to a pain clinic or something, are they going to be able to provide this? Is it going to be covered by insurance? So this is when that external validity comes into play of like, okay, yes, internally the paper, solid methodology, low risk of bias, great. We should be, recommending this to patients. And then there's reality. What are the logistics? What's the coverage? What's my patient population, et cetera, et cetera, et cetera. So, and that comes too into the evidence-based medicine. That's one of our stools is like, okay, our patient desires, right? So we have evidence to support it. We have clinical expertise, in which case I don't have much when it comes to this. I'm aware of pain education, but I myself am not, fully trained in it as some of these providers are in this paper. And then we have patient preferences and sort of the reality of life.
Yeah, I love that. And that's a really good point. It's like we don't need to fully understand the package, just that it is a package. And if we like the results, we, like you said, we have to be able to refer. And I think your point's well taken that we can't assume that any CBT trained person would necessarily know how to do this, nor that it would be covered by insurance. So those would be the next like external application questions to ask. Love that. Mm-hmm.
Yeah, it looks like in the PRT group, they had a 1-hour evaluation, kind of talking to them about contributors to pain, talked about peripheral versus centralized pain, and then they completed 8 individual 1-hour therapy sessions with a therapist with extensive PRT experience, twice weekly for 4 weeks.
It's intense.
Yeah. And they laid out the treatment protocol in an appendix.
That's all good.
Which we just won't have time today to kind of look over, but you could, I guess, if you were really sort of by the book EBM, you could try to follow that.
This is great, but the fact that they lay that out is fantastic, right? We don't just have to like assume it.
And this is important too. Treatment fidelity was assessed by independent raters coding audio recordings of the sessions.
Very nice. Okay, talk to us about that. What does that mean?
So basically, they had an independent group that's not affiliated with the project, just kind of seeing, okay, are they actually getting the intervention that should be done in a PRT session, or are the clinicians sort of deviating from what would be done in the PRT session that's outlined basically in that appendix, and then how frequently are participants actually attending these sessions. And it looks like there was a mean of 5 out of 6 PRT elements were present in each session. So for the majority, all the things that they were supposed to have in the sessions were present, and they needed at least 3. So there was high treatment fidelity within these sessions.
This is outstanding. So one of the issues you run into, like you said, with external validity is, were they actually getting what they said that they were, what we believe that they're getting? And so having that check is outstanding. So again, yet another feather in the cap. That's good. And then, okay, so that's the intervention arm. So far, so good.
Now is the open label placebo.
Okay.
And what they did was they watched 2 videos describing how placebo can powerfully relieve pain even when known to be inert.
Ah, nice.
Okay, exactly. So they're saying, hey, I'm going to give you a placebo. It can help, but there's nothing in this.
even though it can help, even if you know it's a placebo, which I think is so cool. So they're prepping the mind to benefit. So they're trying to rev up the placebo response here, which is important. This is actually brilliant. Okay, keep on going. This is like, this design is genius. Okay, go ahead. Mm-hmm.
And then they also did a subcutaneous injection described as saline. So basically, it was just salt water. Was administered by a physician at the site of greatest back pain during an empathic, validating clinical encounter.
Wow.
Or an orthopedic medical center.
Neat. So that's their open label placebo.
Yeah.
But it's note that it is very rich in non-specific effects of intervention. So all the things that we know would maximize the placebo response. So they are not gaming the system to benefit their intervention. They're trying to game the placebo response, which is very rigorous. Yeah. I've never seen anything so rigorous with a placebo control.
I like to term that as theatrical placebo, because
yep.
There's this theater around it of, oh, they're coming to me with this injection, and they're talking to me about the mechanism of action, and something's actually being done to me, and I'm seeing it, therefore I should be getting better. It's cutting edge medicine, when really it could just be a placebo.
This is so cool. So all those benefits are being maximized. Very amazing. And then they were also asked to continue their ongoing care. Okay, so that's the usual care. So can I just say why I think, so this is like brilliant on a zillion levels, but here's the thing, is normally what you get with these low back pain trials is intervention compared to usual care. And one of the major arguments against that design, even though that's standard, is that the intervention, so it's basically so let's say A is the usual care. So it's usual care plus intervention, so A plus B versus A. So even though you're getting usual care, and it's like open label in that way, you're not actually controlling for the placebo effects of the intervention. And so even though it's sort of semi-controlled, you don't control for that. So these guys, this is so cool. So they gave a placebo to usual care plus placebo in this group. So that's basically to deal with the A plus B. And they're like, well, look, our psychological intervention is going to be hardcore theatrics. And so if we're going to give a placebo to control for that, it should also be hardcore theatrics. And they do it. Wow, it's so neat. Wow. Okay, awesome. So that's group 2. And then let's talk about group 3.
And then group 3 is usual care. And actually, this is something that I do quite a bit. So it's going to be interesting to see the results. The participants in this group were given no additional treatment. They just continued their ongoing care as usual, did not start new treatments before the post-treatment assessment. And then after that post-treatment assessment, so basically at the end of the trial, they were given a chronic pain workbook to access, which was from unlearnyourpain.com. I often do refer patients to sort of like Explain Your Pain. That's sort of like a well-known, sort of validated chronic pain sort of type of treatment resource. And so, they basically, for usual care, was basically like under, the guidance of their treating physician. And then at the end of the therapy, it was said, hey, here's a workbook, go.
Yeah, I guess for ethics, right? It's like, so that they get something at the end. So you've got patients with chronic back pain. One group is like, just keep on doing what you're doing, guys. The other group is like, keep on doing what you're doing and do this really cool thing that we invented. And then the other group is, keep on doing what you're doing and do this like highly theatrical placebo injection as well. Wow. Okay, so cool. Loving it so far. All right, let's move on to, so those are this, and let's just say, looking at the flowchart real quick, they randomized 151 people, about 50 to each group. They are detailing who dropped out and why, which is very important. And the thing that just warms the cockles of my heart is that at the end they say all available data were included in the analysis. And
there wasn't very many who dropped out. So in the PRT group, they started with 50, 44 completed treatment. In the placebo group, 51 were included, 44 received treatment, and then it looks like no one dropped out of the usual care group.
So pretty balanced between the quote-unquote active arm, or the placebo arm, and the PRT arm. as far as dropouts, and they explain the reasons for dropout too, like an emergency, didn't start it. They explained how many were monitored at each endpoint. This is outstanding. And then all available data were used. So it doesn't look like they censored any information either. So again, this is a very rigorous, conservative design so far. So far, all check marks, and I'm like still geeking out about their control arm. All right, so let's talk about clinical measures, how they're going to measure the effects.
Sure. So the primary outcome was average pain over the last week.
Makes
on
sense.
a scale of 0 to 10. I think that's totally fine. Assessed at the 1 month post baseline session. And then we also, and I think this is also important too, we also calculated the proportion of participants who reported a pain reduction of 30% or more. And I find that when it comes to like minimally important clinical differences, that's typically where we start off is like how many people are getting at least a 30% improvement. Pain reduction of 50% or more. So how many people reported at least half their pain improving, and a pain score of 0 or 1. So basically, how many are achieving remission, if you will. Secondary outcomes included promise, their scores on a promise score. So promise is basically like a lifestyle, or not lifestyle. It's kind of, well, yeah, you could say like lifestyle. Like how much is this affecting your quality of life, basically. They also did short forms for depression, anger, anxiety, sleep quality, and then affect. So I think that's really fine, because pain does affect all of those things. I'm not sleeping because of my pain. My pain is affecting my mental health. And so I think that those are totally reasonable secondary outcomes. So remember, they're secondary outcomes. Really, this paper is about the primary outcome. So if they're not showing improvements in the primary outcome and kind of highlight the secondary outcomes pretty hardcore, then that the results really weren't that favorable, and they're trying to kind of skew how it's being perceived.
Yeah, and I like that they're dichotomizing by like reasonable thresholds of pain relief too, instead of just saying, oh, there's, we're just measuring if there's a difference. This is outstanding. And yeah, I agree. All your secondary outcomes are reasonable and validated.
And then they did some other pain belief scale stuff that I really don't care about. I think if you're interested in it, you can totally read it. But I think from a clinical standpoint, they're nothing too exciting.
Yeah, I guess if from a mechanism perspective, so like Tampa scale of, how do you pronounce that? Kinesiophobia?
Kinesiophobia, yeah.
Kinesiophobia, pain catastrophizing scale, survey of pain attitudes, emotion subscale. So these would be things you would imagine, I guess, would be elevated in people that would respond or to this sort of intervention. Is that reasonable?
And maybe if you're like if you work within like a pain specialty clinic, those may have some more importance to you. But from a primary care standpoint, I don't care about those. I really care more about like, hey, last week you said your pain was at a 9 out of 10. Where are we at now?
Sounds good. All right, keep on going. This is good.
Okay, then they did their fMRI. They described that. And during fMRI, participants completed an evoked back pain task and a spontaneous pain scan.
So like ask them to, I'm assuming that means like ask them to move in a way that would evoke pain and then see.
Or getting kicked in the back by the clinical team.
Pretty sure that wouldn't pass ethics.
And then the spontaneous pain scale, in which participants rested and rated ongoing pain once per minute. Interesting.
This is so cool. And look at this other thing they did that's so neat. So during fMRI, participants completed an evoked pain task with a series of randomly ordered trials descending the back 1 to 4 intensity levels. So like the order of it was randomized too, so that it couldn't be, I assume, so that it couldn't be intuited, and you would see responses from like what they thought was going to happen next or something. This is like very rigorous and thoughtful design. So cool. Okay, sweet. What else you got?
Statistical analysis. So very first thing we see is intent to treat analysis was performed for the primary outcome. We'd love to see how direct they are with that. And then they kind of geeked out as to what that really entailed, as to how they looked at it. So they did a 2x2 time interaction with covariates.
Yeah, and I don't think a normal reader would need to do this. I think, like you said, just noting that it was intent to treat is good.
Yeah.
And then they calculated treatment response rates for 30% or greater, 50% or greater. Okay, this is good. Those missing. Okay.
And then this is important.
Yeah.
At the end, we also tested the reverse, whether pre-treatment to post-treatment pain reductions mediated treatment effects on pain beliefs at follow-up.
Oh, and okay, so this is so cool. And okay, wait, so sorry, say that I was reading something else. Sorry, say that once more.
We also tested the reverse, whether pre-treatment to post-treatment pain reductions mediated treatment effects on pain beliefs at follow-up.
Oh, that's interesting.
Controlling for baseline pain beliefs.
Oh, that's neat as well. Okay, so that's cool. So that's fabulous. And then get this, dude. So then they say those with missing data were considered non-responders. So not only are they using all the data that they have available, but they're being as freaking conservative as they can. So if people just dropped out and they said, yeah, my pain went from like a 10 to a 5 and then they disappeared, they don't just assume that those next follow-ups are still at a 5 or improved. They assume they were non-responders, a negative response. So again, if we still see a response, it's going to be all the more impressive. So again, very rigorous, very conservative in how they're dealing with this. This is like getting me all excited from an EBM perspective.
Yeah, dude, our nerd propeller hats are spinning at full speed right now.
Yeah! It's so true. I'm like, this is amazing. Okay. Oh, I want to meet these people. They're like so cool. Can we be friends? All right. So, what else? I think we're good. I want to make sure we finish methods before the end of today, and then we can pick up with results, which I'm like really excited. I hope they're positive because they had such a rigorous design here.
They still don't really explain what the evoked back pain is. They just said an evoked back pain localizer identified brain regions associated with evoked back pain intensity. I'm saying they kicked them in the back and then did fMRI on them. That's.
I think they asked them in random order to like move in a way that would cause pains from like what they say 1 to 4 or something. But maybe they just kicked them in the back. That could be possible. Check supplement 2. Apparently that's where that is detailed given in more detail.
Detailed photos of it getting kicked in the back.
Yeah, detailed photos and the ethical sign off. And then they have what's this last thing here? Spontaneous pain connectivity. This might just be fMRI stuff.
Yeah, that's the fMRI on the spontaneous pain that's being reported. So when they're just sitting there and reporting their pain on like every minute on the minute.
Okay. Okay, love it. Okay, so this is great. So let's leave it here. This is perfect. I think this is how, and I would love to hear from the listeners if this is useful to them, because I personally feel like modeling how we would look at these papers without any prep is important, like what we're looking at, because that's what's going to happen in real life when you're looking at papers. You're not going to have hours to prepare it as if it's a lecture. So we'd love feedback if this is useful to you as well. I like these off-the-cuff stuff. But yeah, so I would say let's do our quick take-homes on this. My main take-home, yeah.
Well, do we want to at least report what the primary outcome finding was?
No, let's do results next time. Let's keep people in suspense. Wow. Yeah, because let's keep people in suspense.
Well, I hope everyone enjoyed our first half hour as to how chaotic our life is right now, and then even finish the paper.
Yeah. Well, again, let's get the feedback. We'll get some feedback here, but there'll be some dropout issues because if you hated this and never listen again, we're not going to hear back from you. So we've got some own bias issues on that one. But so thank you, Bill, for this excellent paper referral. I look forward to.
Stay tuned for the results.
And stay tuned for the results. Nerd alert from us, loving the design, but clearly emphasizing the conflicts with the authors. But again, this dovetails perfectly with our discussion about conflict of interest in industry last time, because the timing couldn't be more perfect. Because essentially it's like, okay, if you're in a situation where you want to get this study done to help people, and you are the only people that can do this or can fund it, how do you, and granted that there's not enough research going on, and there's not enough NIH funding, how do you make this happen in a way that minimizes or negates the risk of bias? I think so far, to me, this is how you freaking do that.
Yeah.
Cool.
No, this is a really cool. This was a great paper.
Okay. Awesome. Stay tuned. Good luck, Adam, in your move.
Thank you.
And next time we talk to you, you'll probably be in Vermont, coming live from Vermont. And
No, I'll be coming probably live from somewhere in the United States.
oh, you're taking some time to travel. Are you coming down to Colorado? You are coming down to Colorado, right? Okay,
Yeah.
awesome. Let me know what days you're.
Maybe we finish the podcast episode there. That'd be cool.
Okay.
In your recording studio, your super fancy recording studio.
Yeah. No, it's really nice. I've got maybe I'll do soundproofing before you come, make it really impressive.
Okay. We'll both be over caffeinated. We'll just drink coffee the whole time before.
Yeah. This is our way. This is our way. We just need to accept who we are. All right, listeners. Thank you so much, Adam. Safe travels, and I'll see you when you get down to Colorado.
All right. Awesome. Thank you, everyone.
If you enjoy this podcast, chances are that one of your colleagues and friends probably would as well. Please do us a favor and let them know about the podcast. And if you have a little bit of extra time, even just a few seconds, if you could rate us and review us on Apple Podcast or any other distributor, it would be greatly appreciated. It would mean a lot to us and help get the word out to other people that would really enjoy our content. Thank you. Hey, y'all, this is Josh. We talked about some really interesting stuff today. I think one of the things we're going to do that's relevant, there is a course we have on Dr. Journal Club called the EBM Boot Camp that's really meant for clinicians to sort of help them understand how to critically evaluate the literature, et cetera, et cetera. Some of the things that we've been talking about today. Go ahead and check out the show notes link. We're going to link to it directly. I think it might be of interest. Don't forget to follow us on social and interact with us on social media at Dr. Journal Club, DR Journal Club on Twitter. We're on Facebook, we're on LinkedIn, et cetera, et cetera. So please reach out to us. We always love to talk to our fans and our listeners. If you have any specific questions you'd like to ask us about research, evidence, being a clinician, et cetera, don't hesitate to ask. And then, of course, if you have any topics that you'd like us to cover on the pod, please let us know as well.
Thank you for listening to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.
If you enjoy this podcast, chances are that one of your colleagues and friends probably would as well. Please do us a favor and let them know about the podcast. And if you have a little bit of extra time, even just a few seconds, if you could rate us and review us on Apple Podcast or any other distributor, it would be greatly appreciated. It would mean a lot to us and help get the word out to other people that would really enjoy our content. Thank you. Hey, y'all, this is Josh. We talked about some really interesting stuff today. I think one of the things we're going to do that's relevant, there is a course we have on Dr. Journal Club called the EBM Boot Camp that's really meant for clinicians to sort of help them understand how to critically evaluate the literature, et cetera, et cetera. Some of the things that we've been talking about today. Go ahead and check out the show notes link. We're going to link to it directly. I think it might be of interest. Don't forget to follow us on social and interact with us on social media. At Dr. Journal Club, Dr. Journal Club on Twitter. We're on Facebook, we're on LinkedIn, et cetera, et cetera. So please reach out to us. We always love to talk to our fans and our listeners. If you have any specific questions you'd like to ask us about research, evidence, being a clinician, et cetera, don't hesitate to ask. And then, of course, if you have any topics that you'd like us to cover on the pod, please let us know as well.
Thank you for listening to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.